Sure. Let me start with Ambassador. The Ambassador is a landmark, phase 3 trial that looked at adjuvant pembrolizumab in patients with high-risk muscle-invasive urothelial carcinoma undergoing surgery. It included both upper tract and bladder and urethral carcinoma. And essentially, the trial is positive. It showed an improvement in disease-free survival with a hazard ratio approximately 0.7. There was an approximate doubling of the median disease-free survival from around 14 months to close to 29 months. And so this was also published concurrently with the presentation here in the New England Journal of Medicine. So we anticipate that this might lead to approval of pembrolizumab in the near future for the adjuvant therapy of high-risk disease. As we know, adjuvant nivolumab is already approved in this setting, so I think we might have a second agent in the same space in the near future. Now, continuing with the second study you mentioned, which is the NIAGARA trial. The NIAGARA is also a phase 3 trial of little over 1,000 patients, a big trial. So this is a trial that looked at neoadjuvant, so preoperative in muscle-invasive bladder cancer, cisplatin gemcitabine or cisplatin gemcitabine combined with durvalumab. And in the experimental arm, patients also received adjuvant durvalumab postoperatively for 9 more months for a total of 1 year of durvalumab. So this trial is positive for the first time, showing that in the perioperative setting, including neoadjuvant gemcis plus minus durvalumab, adjuvant plus neoadjuvant durvalumab, there is an improvement in event-free survival with a hazard ratio of 0.68 and an improvement in overall survival with a hazard ratio of 0.75. So we expect these data to be practice-changing. At the moment, we use only cisplatin-based combination therapy, so now we have to consider adding durvalumab to these patients in the neoadjuvant setting. One more key aspect of this trial was, although this was a cisplatin-based chemotherapy backbone, there were patients with some renal dysfunction, moderate renal dysfunction included with the 40 to 60 estimated GFR. And in these patients, split dose weekly cisplatin gemcitabine was given. And therefore, this extends the neoadjuvant space to cisplatin ineligible patients, formally by definition, the 40 to 60 group, where we can consider split dose cisgem plus durvalumab based on the NIAGARA trial. And now, continuing with the Checkmate 901 trial, where there were quality of life data presented. So to recall, this is the first-line advanced urothelial carcinoma trial, metastatic or locally advanced unresectable disease, where cisgem versus cisgem nivolumab was compared, and there was an improvement in overall survival with a hazard ratio 0.78 and an improvement in progression-free survival with a hazard ratio 0.72. The key highlight of this trial was that the complete remissions, which were seen in around 22% of patients with gemcis-nivo, was highly durable with a median duration of complete remission of around 3 years, which was enriched in lymph node only disease. Now, what was shown at ESMO 24 is that the quality of life, when you compare gemcis versus gemcis nivolumab, there was not a detriment to quality of life by adding nivolumab to gemcis. So I think that this quality of life data consolidate a role for gemcis nivolumab in the first-line advanced disease setting, of course, cisplatin eligible only, especially in lymph node only disease, but really the overall improvement was seen across overall in the entire trial. But I think that this lymph node only disease patients had most of this benefit. And now continuing with a trial which was a phase 1 trial, just to change the subject a bit. This is of PRT3789. This is a novel first-in-class SMARCA2 inhibitor, SMARCA2, SMARCA2 inhibitor, which was looked at in patients with SMARCA4 altered tumors across all solid tumors. So the SMARCA4 and SMARCA2 are part of the SWE/SNF complex, which is involved in chromatin remodeling in tumors. So in tumors with SMARCA4 alterations and loss of function, there is a heightened sensitivity to SMARCA2 inhibition. So it's somewhat like a synthetic lethality. So PRT3789 is a SMARCA2 degrader, which works by proteasome-induced degradation of SMARCA2. So in this trial, 65 patients have been enrolled so far. This is a phase 1 trial, and essentially at this moment, dose escalation is still ongoing. We have not reached the maximum tolerated dose. Out of the 65 patients, around 46 patients are evaluable for efficacy. Among these 46 patients, the ones with efficacy were seen were non-small cell lung cancer and esophagus cancer, which was around 26 patients overall. In this group of 26 patients, there were tumor regressions seen in around 27% of patients. So really the promise seems to be in these two malignancies, but it's still too early. Dose escalation is still ongoing. So I think that this is a novel target in this synthetic lethality background of SMARCA4 altered tumors that is undergoing further evaluation. And furthermore, this drug is going to be combined with docetaxel as well as with pembrolizumab in the near future. So we will see more data from this class of drugs, which is a first-in-class novel targeted agent.